You're listening to Who Said, a cardiology board review series. No fluff, just facts.
This episode is about long-term medications in coronary artery disease. We will talk about post-myocardial infarction medications, especially anti-inflammatories, aspirin, P2Y12 inhibitors, triple therapy where applicable, ACE inhibitors and ARBs, beta blockers, and statins. And then we'll talk about medical management of angina or coronary artery disease that is unrevascularizable, which is a very important topic because symptom management is important at all stages of this disease. Let's start with the anti-inflammatories. What is the role of inflammation in atherosclerotic cardiovascular disease? In atherosclerotic plaque formation and plaque progression, the accumulation of foam cells coupled with the release of inflammatory cytokines such as interleukin-1 beta, interleukin-6, and tumor necrosis factor alpha leads to a thickened arterial wall and a narrow lumen. Inflammatory cells within the plaque release enzymes that degrade the fibrous cap of the plaque, making it more prone to rupture. After an MI, the inflammatory response continues as part of the healing process. While some inflammation is necessary for clearing dead cells and initiating repair, excessive inflammation can lead to adverse cardiac remodeling, which impairs recovery and contributes to heart failure. At this point, you have probably heard all the buzz about colchicine in ASCVD. Why does colchicine work? What is going on? Colchicine is an anti-inflammatory drug that primarily inhibits neutrophil activation and microtubule polymerization and interferes with the production of inflammatory mediators. Specifically, colchicine disrupts the microtubule assembly in neutrophils, limiting their ability to migrate to the site of inflammation. Neutrophils play a critical role in plaque instability by releasing enzymes that degrade the plaque's fibrous cap, promoting rupture. By limiting neutrophil activity, colchicine helps to stabilize plaques, preventing rupture and subsequent thrombosis. Colchicine inhibits the NLRP3 inflammasome, which is responsible for activating interleukin-1 beta. IL-1 beta is a major cytokine that amplifies the inflammatory response in atherosclerosis. Reducing IL-1 beta leads to lower levels of downstream pro-inflammatory cytokines such as interleukin-6 and C-reactive protein. There have been pretty major trials with good evidence about colchicine, including the COLCOT trial and the LODOCO-2 trial. The COLCOT trial, which is the colchicine cardiovascular outcomes trial, showed that colchicine 0.5 milligrams per day significantly reduced major adverse cardiovascular events in patients who had a recent myocardial infarction. So that's secondary prevention. In the LODOCO-2 trial, it demonstrated that low-dose colchicine at 0.5 milligrams per day reduced cardiovascular events in patients with chronic coronary disease. Although it had not made it in the guidelines yet, there is already pretty wide consensus and enthusiasm in cardiology for the use of colchicine in ASCVD, especially given the FDA approval for this use of colchicine. So colchicine can be considered in patients with a history of myocardial infarction or patients with chronic coronary artery disease, and those with elevated CRP in these groups may benefit more. C-reactive protein is primarily formed in the liver, but is also secreted by the coronary arteries, specifically from atherosclerotic intima. High-sensitivity CRP levels are low if they are less than 1 milligram per liter, intermediate if they're between 1 and 3 milligrams per liter, and high if they are above 3 milligrams per liter. Statins reduce high-sensitivity CRP levels in a mechanism unrelated to the LDL lowering effect. In the Jupiter trial, statins were shown to reduce cardiovascular events in apparently healthy individuals with LDL under 130 who had elevated hsCRP more than 2 milligrams per liter. In a lot of these papers, thought leaders have been calling for initiation of colchicine in patients who either have chronic coronary disease or history of myocardial infarction with hsCRP levels more than 2 milligrams per liter, whereas other thought leaders are calling for initiation even without checking the CRP. So we'll see what the guidelines come out to say about that. That's anti-inflammatories. Let's move on to aspirin. Aspirin is an irreversible inhibitor of cyclooxygenase, or COX, impairing the formation of thromboxane A2, a potent mediator of platelet aggregation and vasoconstriction. Aspirin should definitely be used as part of DAPT for secondary prevention of ASCVD, but it has fallen out of favor for primary prevention. Aspirin might be considered for primary prevention of ASCVD among select adults aged 40 to 70 who are at higher risk of ASCVD but not at increased bleeding risk. That's a Class 2B recommendation. Aspirin should not be administered on a routine basis for the primary prevention of ASCVD in adults more than 70 years of age. That's a Class 3 recommendation. Aspirin should not be administered for the primary prevention of ASCVD among adults of any age who are at increased risk of bleeding. Class 3 recommendation. The presence of other NSAIDs may prevent acetylation of COX by aspirin. Use of ibuprofen may inhibit the effects of aspirin on COX and reduce aspirin's antiplatelet efficacy. So we advise patients to avoid taking NSAIDs while they are on DAPT. Aspirin and P2Y12 inhibitors make up DAPT, or dual-antiplatelet therapy. DAPT is primarily used to prevent in-stent thrombosis, or IST, in the early weeks after PCI. Platelet aggregation and thrombosis are the primary drivers of in-stent thrombosis, which can lead to myocardial infarction shortly after stent placement. What's exactly happening at the cellular level? When a coronary stent is deployed, it disrupts the endothelial lining, exposing the underlying collagen and tissue factor, which activates platelets and activates the coagulation cascade. Clopidogrel, ticagrelor, and prasugrel inhibit the P2Y12 receptor on platelets. Normally, when adenosine diphosphate binds to the P2Y12 receptor, it activates platelets, triggering a cascade that amplifies platelet aggregation and stabilizes the formation of a thrombus. P2Y12 inhibition leads to reduced platelet activation and aggregation by blocking this ADP-mediated amplification process. Meanwhile, aspirin irreversibly inhibits the cyclooxygenase 1 enzyme in platelets, which leads to a reduction in thromboxane A2 production, a potent vasoconstrictor and promoter of platelet aggregation. By decreasing thromboxane A2, aspirin reduces platelet activation and aggregation. Together, these two agents in DAPT significantly reduce the risk of clot formation, i.e. reduce the risk of in-stent thrombosis, particularly in the first weeks that are critical, for the first weeks to months that are critical after implantation when the stent is most thrombogenic. How long should you continue DAPT? According to the AHA-ACC 2016 guidelines, DAPT length after PCI for SIHD, which has now been renamed chronic coronary disease, normal bleeding risk would be 6 months if drug-eluting stent, 1 month if bare metal stent. That's a Class 1 recommendation. For DAPT length after PCI for stable ischemic heart disease, again, relabeled to chronic coronary disease, high bleeding risk, then 3 months if drug-eluting stent, Class 2B, and 1 month if bare metal stent, Class 1. The recommendation is actually the same for the DAPT duration after PCI, after CABG for ACS, and after CABG for chronic coronary disease and medically managed ACS. The preference is very much so 12 months if it's a normal bleeding risk, that's a Class 1 recommendation, and 6 months if high bleeding risk, that's a Class 2B recommendation. The earliest you can interrupt the DAPT, and beware that interrupting DAPT is not the same as stopping DAPT. When you interrupt DAPT just for the surgery, you resume it and then continue it for the rest of the duration. So when we say that we really want patients to be on 12 months of DAPT if they have normal bleeding risk and 6 months of DAPT if they have high bleeding risk after an ACS event, that doesn't mean that you have to wait 12 months for the surgery or 6 months for the surgery. The total duration of your DAPT is not necessarily the time that you can interrupt it at earliest. So the earliest DAPT interruption you can do for surgery is 1 month for a bare metal stent. For drug-eluting stent, the guidelines from 2016 say 6 months, but in practice, there's kind of some leeway and risk benefits and shared decision-making with patients so that it's something less than 6 months. These guidelines are 8 years now. Hopefully, there will be an update in the next year or two. They did come out with one statement in the 2021 ACC/AHA SKY guideline for coronary artery revascularization, which said, since the release of the 2016 guidelines, more recent trials have been published. For this reason, this additional recommendation for DAPT is provided. In selected patients undergoing PCI, shorter duration DAPT of 1 to 3 months is reasonable, with subsequent transition to P2Y12 inhibitor monotherapy to reduce the risk of bleeding events. That's a Class 2A recommendation that they added on top of the existing 2016 guidelines. So up till this point, the 2016 guidelines on DAPT are still the latest ones in AHA-ACC. The ESC has since put out more modern guidelines, but we'll see what will happen in the next couple of years here. The CURE study showed that DAPT carries a 20% reduction in ischemic endpoints regardless of whether patients were given revascularization or medical management, and the benefits of DAPT occurred as early as days after the MI. CAPRI showed that in patients with atherosclerotic vascular disease of any sort, ischemic stroke, recent MI, symptomatic PAD, clopidogrel 75 mg is superior to aspirin 325 mg for preventing ischemic events by a small margin. So in patients with contraindications to aspirin monotherapy after one of these ischemic events, they should be put on clopidogrel 75 mg daily. Paris showed that the combination of aspirin plus dipyridamole was not superior to aspirin alone for secondary prevention of MI. Moreover, dipyridamole can provoke exercise-induced ischemia, so it is not recommended for secondary prevention of MI. Class 3. Other than dyspnea, ticagrelor also causes ventricular pauses, which are rarely symptomatic. What about the situation when a patient who is already on a DOAC because of AFib gets a stent for MI and needs to be on DAPT? This is a very common situation. The 2020 ACC Expert Consensus Decision Pathway for Anticoagulant and Antiplatelet Therapy in patients with atrial fibrillation of venous thromboembolism undergoing percutaneous coronary intervention has several valuable things to say about this. They say, we recommend against the routine use of triple antithrombotic therapy for most patients. Accordingly, for patients requiring both an anticoagulation and an antiplatelet, we strongly recommend the default strategy after recent PCI be dual antithrombotic therapy consisting of an anticoagulant and a P2Y12 inhibitor. When triple antithrombotic therapy is to be utilized, we recommend that it be done for a limited time duration, the shortest period possible, in patients at high thrombotic risk. For example, if the patient is perceived to be at particularly high risk for coronary thrombosis and the bleeding risk is judged to be low, aspirin may be added to a P2Y12 inhibitor and anticoagulant for up to 30 days following PCI. In the setting of a recent PCI, the preferred antiplatelet is P2Y12 inhibitor, for 6 months for chronic coronary disease, for 12 months for acute coronary syndrome. For patients requiring an indefinite anticoagulant therapy, we recommend that the antiplatelet be continued for 1 year post-PCI, as the safety and efficacy of an AC alone after a short duration of antiplatelet has not been tested. As an example, if a patient requiring indefinite anticoagulant therapy undergoes PCI for chronic coronary disease, clopidogrel would be used for 6 months post-PCI. Beyond this period, single antiplatelet therapy with either aspirin or clopidogrel should be continued for an additional 6 months along with the anticoagulant. Thereafter, anticoagulant therapy alone could be used in the long term. They also say that we recommend clopidogrel over other more potent P2Y12 inhibitors and DOACs over vitamin K antagonists like warfarin when combination antithrombotic therapy is needed. So if you have somebody with AFib and comes under PCI, unless there are different circumstances like complex coronary anatomy that necessitate it, I would try to use clopidogrel instead of ticagrelor or prasugrel when you are doing it in conjunction with a DOAC such as apixaban because of AFib or VTE. That's what this this particular guideline is trying to say. For patients who are not candidates for a DOAC and require treatment with a VKA like warfarin, it is reasonable to aim for the lower end of the target INR range. For example, 2.0 to 2.5 instead of 2.0 to 3.0, with more frequent INR monitoring to reduce bleeding risk. For patients undergoing PCI, the characteristics and morphology of the vessel, lesion, and stent location may influence decisions about DAPT duration and the safety of shortening it, irrespective of the type of stent used. Higher risk lesion characteristics include bifurcation lesions, thrombus-containing lesions, long lesions, among others. But if there is uncertainty, it should be discussed with an interventional cardiologist on a case-by-case basis. Now we'll move on from DAPT and triple therapy to ACE and ARB. ACE and ARB should be initiated in all patients who have a STEMI. That's a Class 2A recommendation from the AHA-ACC, especially if it is an anterior STEMI, which gets a Class 1 recommendation. What about NSTEMI patients? In NSTEMI, non-ST elevation MI patients, ACE or ARB should be initiated if they have heart failure or LVEF of 40% or less. That's a Class 1 indication. Of course, if they have concomitant CKD, diabetes, or hypertension, then obviously you also use an ACE inhibitor or ARB. That's a Class 1 recommendation. But if they don't have any of these things, no CKD, diabetes, hypertension, or HFrEF or heart failure, then you don't really have an indication to start an ACE or ARB in this NSTEMI patient. Okay, so that is a subtlety you need to know about. The duration of ACE-ARB post-MI is indefinitely. ACE inhibitors reduce mortality and morbidity during and after an MI when the patient has reduced EF. The greatest benefit accrues in the first week post-MI. 1/3 of the mortality benefit supposedly occurs within the first 2 days of ACE use after MI. There is a 20 to 30% relative risk reduction in mortality over 3 years of follow-up when ACE inhibitor is used post-MI with reduced EF. ACE inhibitors and ARBs have a beneficial effect post-MI because they increase production of nitric oxide, decrease aldosterone secretion, lower sympathetic tone, and reduce adverse LV remodeling. ARNIs, such as Entresto, aren't used in place of ACE-ARB post-MI because Paradise MI was negative. Now let's move on from ACE-ARB to beta blockers. Although the optimal duration of beta blocker after a STEMI remains unclear, current guidelines recommend continuation of beta blockers for at least 3 years following STEMI in patients with normal LVEF. In patients with reduced LVEF, then of course you treat the beta blocker just like a HFrEF GDMT and you'll continue it indefinitely. For beta blockers, I talked about beta blockers and STEMI, you get at least 3 years. But what about the other situations? If there is LV ejection fraction that's under 40% inclusive or prior MI, then you should use carvedilol, metoprolol, succinate, or bisoprolol for survival and ventricular performance. If there's vasospastic angina or severe PAD, you should use carvedilol, labetalol, or nebivolol. If they do not have reduced ejection fraction, and it was not a STEMI, then it's questionable. It's open-ended whether you should be putting a beta blocker on. They do have one recommendation in the guidelines about this that says, in patients with stable ischemic heart disease and normal left ventricular function, the routine use of chronic oral beta blockers is not beneficial to reduce cardiovascular events after complete revascularization. That's a Class 3 no benefit statement. Brief word on statins. Post-ACS, we increased the statin to a high-intensity statin and max dose because the Prove-It TIMI-22 trial showed superior long-term outcomes with a high-intensity statin, atorvastatin 80 mg daily, compared to a lesser-intensity statin, such as pravastatin 40 daily. Statins are covered in greater detail in a lipid-lowering episode, so that's all I have to say about it here. Now, to the other part of this episode, we're going to talk about medical management of angina and medical management for CAD that is not revascularized in terms of symptom improvement. The first line are beta blockers. How do they work? Beta blockers decrease myocardial oxygen demand by reducing heart rate, contractility, and LV wall tension by lowering systemic arterial pressure. Regardless of differences in cardiocell activity, intrinsic sympathomimetic activity, vasodilating properties, and relative lipid solubility, all beta blockers appear to be equally efficacious in chronic coronary disease. Beta blockers decrease symptoms, increase survival, and decrease reinfarction. Other things you can try are nitrates, calcium channel blockers, and ranolazine. Let's start with nitrates. Nitrates lead to smooth muscle relaxation and have venodilatory, coronary, and arterial effects. The primary anti-ischemic effect is from a reduction in left ventricular wall stress via systemic venodilation. Nitrates decrease symptoms but have no impact on survival or reinfarction. Nitrate side effects other than headache and hypotension are reflex tachycardia, methemoglobinemia, flushing, syncope, and postural hypotension. Nitrates are contraindicated by critical AS and HCM, so remember to check those first. Nitrates would worsen outflow tract obstruction, and aortic stenosis patients have a fixed cardiac output and cannot tolerate hypotension from nitrates. Sildenafil or Viagra cannot be used within 24 hours, and tadalafil cannot be used within 48 hours of using nitrates. Calcium channel blockers. Calcium channel blockers have anti-ischemic effect by vasodilating and reducing myocardial oxygen demand. By blocking calcium flux into the vascular smooth muscle cells and myocytes, the intracellular calcium release response is reduced, thereby decreasing contractility of smooth muscle cells and myocytes. Calcium channel blockers decrease symptoms but have no impact on survival or reinfarction. Ranolazine is also an option. Ranolazine works by inhibiting the slowly inactivating component of the cardiac sodium current, the late INA channel, reducing the deleterious effects of intracellular sodium and calcium overload that promote myocardial ischemia. Unlike beta blockers, nitrates, and calcium channel blockers, ranolazine exerts its anti-ischemic effect without depressing the heart rate and blood pressure, so it can be useful in that respect. Ranolazine decreases symptoms but has no impact on survival or reinfarction. The main side effects of ranolazine are dizziness, headache, and constipation. Because ranolazine produces a dose-dependent prolongation of repolarization and a QT interval, there was previously concern that it may precipitate arrhythmia such as torsade de pointes, but trials have shown no significant difference in the rates of ventricular arrhythmias or sudden cardiac death in patients receiving ranolazine compared with placebo. Ranolazine is metabolized by CYP3A in the liver, so ranolazine cannot be used in patients with significant hepatic disease. Ranolazine recently got upgraded from Class 2A to Class 1 in the 2023 guidelines as a second-line agent for anginal symptom control for patients with stable ischemic heart disease with continued symptoms despite the use of beta blockers or who cannot use acceptable doses of beta blockers. All right, we have come a long way. Let's close up by hearing from the 2023 AHA-ACC guidelines for the management of patients with chronic coronary disease and see what they have to say about anti-anginal therapy. In patients with CCD and angina, anti-anginal therapy with either a beta blocker, calcium channel blocker, or long-acting nitrate is recommended for relief of angina or equivalent symptoms, Class 1. In patients with CCD or angina who remain symptomatic after initial treatment, addition of a second anti-anginal agent from a different therapeutic class of beta blockers, calcium channel blockers, or long-acting nitrates is recommended for relief of angina or equivalent symptoms, Class 1. In patients with CCD, ranolazine is recommended in patients who remain symptomatic despite treatment with beta blockers, calcium channel blockers, or long-acting nitrate therapies, Class 1. This is the Class 1 statement that I mentioned just now was upgraded from the 2A to Class 1 in the most recent 2023 guidelines. In patients with CCD, sublingual nitroglycerin or nitroglycerin spray is recommended for immediate short-term relief of angina or equivalent symptoms, Class 1. In patients with CCD and normal LV function, the addition of ivabradine to standard anti-anginal therapy is potentially harmful, Class 3 harm. So we've gone over long-term medications for coronary artery disease, including post-MI medications, anti-inflammatories such as colchicine, aspirin, P2Y12 inhibitors in DAPT, triple therapy, ACE inhibitors and beta blockers, ARB, statin, and medical management of angina for symptom relief, including calcium channel blockers, nitrates, beta blockers, and ranolazine for symptom relief. That's all for this episode.
This podcast is intended for qualified healthcare professionals and is designed for training purposes only. These materials should not be used for direct patient care or as a substitute for independent clinical judgment. For more educational content or to submit suggestions, visit www.rehu.com/meded.